Hello, 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 everybody. Welcome to the Recovery Capital podcast. My name is Joanna Dolan. And a real quick thing about Recovery Capital. Recovery Capital is the internal and the external resources that we develop that help us to obtain, maintain, and sustain recovery. And today we've got a really awesome unicorn of a guest. But before he introduces himself, Amy, would you like to introduce yourself?
Yeah, absolutely. My name is Amy DiPietro. I am the coordinator for alumni affairs for Colmac Outpatient Recovery Centers, as well as a patient advocate. And I too am a person in long-term recovery. So this is something weekly that Joanna and I get to do, and it's extremely exciting. And we're really excited to have our guest with us today.
With that, I'll take that as my clue to introduce myself. So my name is John Dombrowski. I'm a physician. I'm an anesthesiologist. I also do pain medicine, but more importantly, I do addiction medicine. I'm a native Washingtonian. Born at Georgetown, as I stated earlier, and went there for medical school. And I did my training up at Yale, New Haven, and then had a practice in Richmond, Virginia, but had an opportunity, I would say about 25 years ago, to come back to the Washington area. You might wonder why there's this intersection between, as an anesthesiologist and pain medicine and addiction, is that so often I saw many patients in recovery centers actually kind of got started on the wrong path with pain medications. And so I felt there was an obligation as a physician to really, put my shoulder to the wheel to see what we can do to help these patients in terms of recovery. But more importantly, now that they're in recovery, what do they do about their pain? And that's really important too. So, we're trying to take care of, two things at once. And I look forward to having that conversation with you.
Oh my God, this is fantastic.
Yeah, for sure. Good. It's a good thing that there's people like you out there.
Thank you.
Because you're right. So for example, I was an opiate user, but I'm one of the ones that it didn't start from an actual injury, right? I just went a different direction, but you used and abused opiates for sure. But I have heard countless stories of people that hurt themselves. They're in a car accident or they have an injury and it plagued them with pain. And then honestly, it seems to snowball very quickly.
Yeah, you're exactly right. Actually, the American Society of Anesthesiology has done a study just looking at dental pain. So these are wisdom teeth extraction. So who gets wisdom teeth? They're usually teenagers. And they really found within 20, probably under a day or two, probably by the second or third day, they've really become dependent or, felt pretty good with that hydrocodone or the Vicodin they received. And it's really, so we've kind of made a warning to parents as well as to oral surgeons or dentists who might be performing this, saying, really limit the exposure of opiates for those patients. I mean, clearly they're in pain, but you want to look at, is there other choice that we have for pain control? Because teenagers are very clever individuals, certainly more clever than I am. And then so they realize, hey, House is getting her wisdom teeth out. Hey, great, let's text for your number, and if she gets some Vicodin, let's split it up. So this is a real problem. We not only have, that one individual, perhaps an issue with dependency, maybe or maybe not. But the other aspect is the medications are getting injected into the community, and you have the risk of diversion. And obviously the physician who's writing or the dentist writing that medication has no idea of this. But again, we need to be cautious in terms of, who we write for. It's appropriate. Pain medication is always appropriate, but then the number we write for. So to kind of look at those two aspects.
When you say the number, you mean like the quantity that would be given? Yeah.
Right. Exactly. So, you always, in my line of work, if people need pain medicine, which is appropriate at times, then you want to make sure that we're not giving you 4 pills a day, but maybe 2 a day or 1 a day. And the physician can figure out how many milligrams you take. So they just figure that out in terms of, well, you're going to get 1 or 2 versus 4. Because if you do 4 a day, let's say it's for a month's supply, that's 120 pills out there. Well, maybe I only need 100 and 20 gets sold or out in the community somewhere. So, if you decide, you as the patient decide to divert the medication, that's fine by me, but that's 1 less for you. So, this is a way of kind of bridging making sure people get appropriate, pain control, but also we're not having a problem with drug diversion or introduction of drugs into the community, because that's our responsibility, at the end of the day.
Yeah, it's so funny you mentioned dental or wisdom teeth. So so I had my wisdom. It was my senior year of high school, and I had my wisdom teeth out.
Yeah,
I was given. It's a long time ago, so I'm not sure, but it was something. It was a Vicodin or perks or whatever it was, and I was only on them for just a few days, but I remember, like, to this day, 41 years old, I remember the euphoric feeling being under those. And so fast forward to a couple of decades later, when I got involved with them again, it sounds strange, right? Like, alcohol has always been an issue for me, right?
Okay.
I've ebbed and flowed with other drugs throughout my journey in addiction. Cocaine, weed, what the kids call it, Molly nowadays, whatever. Oh my God, I'm totally spacing. Anyway, but I was at different points, I was able to put those things down.
Right.
And I tell you what happened. I got a DUI. Got a DUI, and I had to get the interlock system put on my car.
Okay.
So it affected the way I was living. More specifically, it affected my partying.
Sure.
I'm not a child anymore. I mean, I'm in my late 20s, early 30s when this happened. And at that time in my life, I remembered what it felt like when I got my wisdom teeth out. And that is how I ultimately ended up on opiates. And that's really what brought me to my knees and ultimately to the door of recovery. Was that. So that's how powerful that was for me. So, and I know everybody's experience is different, but I'm curious with your experience in being kind of in this field. Certainly there's an awful lot of press these days around the opioid crisis, right? I mean, you see it a lot in print.
Right.
I'm a believer that it's been a problem for a lot longer than it's been around in print. What do you think on that? Like, how long it's been?
Well, sure. I mean, obviously there's two components of, we've always had drug use or misuse, alcohol abuse or anything, because we're human beings. We like a certain feeling, and we like that euphoria. Who wouldn't want that? And again, these are all dopamine related chemicals in the brain. Now, dopamine is what is released when you get a hug or you're in love, and these deep emotions, having sex, or all these things. Who wouldn't want that? This is what this is very limbic, very deep in your, in your brain, very basic type of things. So if you found a chemical to help release that more, why wouldn't you go for that? It's very seductive, but it's understandable. And that's kind of how the opiates do work. So backing up, looking at the opiate crisis. So I do a lot of speaking on this. One, as I said, I'm 59 years old this year. So I went to medical school, I graduated in 89. I got
to interrupt really quick. For those of our listeners that are not viewing but listening, Dr. John looks pretty good for 59. I'm going to throw it out there.
That makes you want to know what he's doing so we can do it too.
So if you're a listener and not a watcher, you might want to look this one up, because Dr. John's an attractive man. All right, I digress.
Thank you. At any rate, I'll come back as another guest. This made me feel very good. See, I got my dopamine. I got my dopamine.
Mission accomplished.
Exactly. So again, back in the early 80s, I mean before that, in the early 90s, we were told never to give people pain medications, because of the risk of addictions. And this would be people with cancer and all that sort of stuff. It's just all comers. And then so we had a very, full idea that these medications are risky, they can cause death, they can cause addiction. Let's not really write them. And sure enough, we didn't. But then again, the WHO, the World Health Organization, looked at pain as a planetary problem. Not a first world problem, but a third world problem. So if I have cancer in the continent of Africa, I'm not getting chemo. I'm not getting surgery. I'm not getting radiation. What's the least we can do? Well, at least make people comfortable. Don't they deserve that? So this is where the World Health Organization came up with a step ladder in terms of pain management. First do Motrin, then a little stronger Motrin, maybe a weak opiate, and then a stronger opiate. The reason we were doing that is out of compassion for these individuals on the planet who did not have first world medication. Well, then fast forward to the early 90s, and they looked at this and go, well, why are we only treating people in third world? People in America are the first will have pain. And that really should be treated too, because pain is all encompassing. I get depressed, I get anxious, I can't get out of bed, I've got risk of all these other things, and you've got a remedy for me here. Why don't you give me these medications? And sure enough, the pharmaceutical industry said, I know who we can do this, Purdue Pharma. We make a pretty long-acting medication that can really have this role. And then the government, the federal agency made pain the fifth vital sign. So when you go to a hospital, they do your weight, your blood pressure, fat, temperature, et cetera. Those are all objective findings. You can step on a scale. You don't tell what the scale is. It tells you what it is. Right. Well, with a pain score, you say what the number is. And, I'm a 10, I'm a 12. Okay, I'm now obligated to take care of that. And then we as physicians were really strong-armed to saying pain medicine, patients with chronic pain is a disease. It must be treated aggressively. If someone came to me with diabetes, why would I withhold insulin? You would give them insulin. So sure enough, a lot of docs started writing pain medication because you told me to do so. And unfortunately, with anything in medicine is like anything, it is a business. Bad attorneys, bad mechanics, bad doctors. And so a lot of them said, fine, you want this? Okay, it's cash only. Okay, that's great. And now when you started doing that, then people needed to get the money, so they stole the medications to make the doctor's appointment to them, and it just doesn't stop.
Yeah,
so then,
wow.
And then we started seeing tremendous rates of death go up. And then what happened when the pill supply got cut off because the DEA appropriately looked at physicians' writing habits, then they really started cutting people off. What did people turn to? People turned to the cheaper format of opiates called heroin. So you had black tar heroin coming up from Mexico saying, hey, instead of paying your OxyContin that's, $1 per milligram on the street, I can get you a lot bigger bang for your buck with black tar heroin. Well, once you start doing one thing illegally, the next thing illegally is not that big of a jump. And then that's what we started. And now what we have is the pendulum has swung the opposite way to go where we're limiting again pain medication. So before we were very limited. We told, everyone gets pain medicine. Now we're back to the other side that we're very limited. But hopefully somewhere, like anything in life, the truth always lies somewhere in the middle. So hopefully what we can start doing is people with chronic pain can get appropriate care. Maybe they need an opiate, but we're going to be cautious. Or maybe we need to look at something else. And that's the interesting thing I like to talk about as an anesthesiologist, is that there are a lot of other medications that have pain relieving qualities that are not necessarily addictive, or don't have equal, or pretty darn close analgesic or pain relief value. And that's kind of important. So people don't know that there is hope out there. A lot of people get very hopeless. Well, my pain medicine's gone. I'm an addict. Now what do I do? There's a lot you can do.
I've heard that that's true for gabapentin.
So you're exactly right. That medication also can be abused. But again, usually, I know it is abused, but I really haven't seen personal experience in my own practice much of that happening, but I know it is out there. And again, a lot of times the way you want to help patients are a couple of things. And physicians are not being difficult. We just want the patient safe. And again, if you're safe, then my practice is safe because it's a medical legal issue.
Yeah.
So a couple of things that a physician could do or probably should do if they're writing you medications is to, number one, have you come in randomly to do a pill count. So random pill counts keep everyone honest. All right. So now,
love that idea.
We might do a urine drug screen. Okay, that means you took one pill. I don't know if you took them the rest of the 29 days. I know you took one. Also, I know you peed positive for whatever. Random pill counts, again, can't predict everything, but on average, if there's been diversion or, geez, I took 6 one day and because I felt kind of poor and 0 the next day, you keep a bit of a handle on that. Again, it can't prevent all aberrant behavior, but it's just a way of protecting the patient, because if we do see a problem, the last thing we'll want to do is support that problem with more medicines. We would say, you know what, looking back here, maybe that's not the right idea for you. Perhaps there's something else that we can do. Tell me about your family history of addiction or use or whatever. Is there something else going on in your life that I'm sad or I'm depressed or I'm anxious? Now, these medications can help with all those things, but perhaps there's a better choice for you out there than a pain medication. But again, you need to bring that patient in and just really have that heart-to-heart, maybe uncomfortable, but a heart-to-heart discussion. And we're not doing it in a punitive way. We're doing it out of a loving way, I think, to say, are we on the right track for you? And that's the big problem.
It's interesting. So just listening to you talk about that, I would say that the exposure I've had in a treatment setting, it feels like one of the desires that come from the medical community is.
Can I ask you that? My office is calling me. Would you mind just putting this on? Can we put it on pause, the podcast?
Oh, sure. Yeah.
Thanks.
All right, we're back.
Yep.
I'm so sorry. Yeah. So basically what I was going to ask was, or comment on, I guess, is that there seems to be a genuine desire to have from the medical community to have the patients learn to become advocates for themselves, like for them to have some skin in the game here. So it's an interaction. It's not just, oh, I have chronic pain, I'm going to go to the doctor, I'm just going to describe it and then wish for the best. But for them to say like, hey, like, okay, you've given me this, but this isn't working for me.
Right. Yeah, I think that is very true. So, I mean, even really before my time as a physician, physicians tend to be very paternal. I mean, they were men, okay, for the most part, but not true anymore. But they would say, I'm the doctor, I'm going to tell you what to do, and you're going to do it.
Right.
And that's about it.
Yeah.
Just like my dad would tell me, you're cutting the grass, and then we're going to do this, and that's
right.
And there was no argument, or if you did argue, they go, well, that's my recommendation. Good luck with that. We now have more of a give and take sort of relationship. I mean, granted, at the end of the day, I'm technically smarter than the patient, okay, technically, but
Right.
It's not my problem. It's not my problem, it's theirs. So my job is sit and listen to the best of my ability and to the patient's best ability to explain what is really going on. And between the two, this interaction, the dialogue, can we come up to a possible solution for their, what they're coming in with? And again, one thing is, I think for a lot of patients is obviously, pain relief is always a laudatory goal. That's great. But sometimes I always ask, people ask what your pain score is. I mean, I don't really care about that. I care about what are you doing? What are you doing better now that you couldn't do before? Well, I'm sleeping better now. Actually, I can't believe how many, women or men, they love cleaning the house. I'm doing this now. I'm picking up the laundry. I'm doing all these types of things. I'm going out shopping. I'm seeing my grandkids. Those are really, and what's your pain? Oh, it's a 12. Okay, but you're clearly more active than before. That's really what you really care about, not the number, but tell me your functionality as a patient, your activities of daily living and your functionality. That's what I always focus on, because at the end of the day, that's what matters, is what are you doing with yourself? And unfortunately, with a lot of these patients, success begets success. I'm more active, my joints are moving, I might be losing a little weight, I feel better because I'm out in the community. These are all positive things that are happening to me. And then sometimes failure begets failure. I'm kind of down, I've got an ache and pain, I'm going to stay here at home, I'm not mobile, I'm not seeing anyone. And then you kind of go in this, down the drain kind of thing. Right. So it can go either way. And the main thing is just to, try to almost be like a coach. Come on, you can do this, a cheerleader. You can do this. Let me get you a little bit comfortable, if I crack that window open a little bit, you can get better. Would that be acceptable to you?
Yeah, I love what you're talking about, because you're right. I can so see that. See it in, without getting specific. I mean, I've been on doctor's appointments with a loved one, and the loved one being my senior. Okay. And I've sat in and listened to her physician do exactly what you're saying. And she's accustomed to being a passive patient.
Right.
Like you were saying, you know, the paternal figure, here's what you need to do. You know, you take 3 of these and you call me in the morning, kind of thing. Right. And so I was watching this whole thing transpire, and I was waiting for her to become an advocate for herself. And it wasn't happening. And so I did it, right? So I spoke on her behalf, but I love the idea that we're trying to create a culture where we are empowering the patients to become an active member of their health, like an active participant rather, in these discussions, because it's important.
No, I mean, and the patient's going to know themselves better than anyone, you know. I mean, I can spend all the time, or, you know, again, at the end of the day, also, physicians' times are somewhat limited, you know. I mean, there is a limited amount of time, unless you're paying concierge money, you know, which is great. But at the end of the time, you only have so much time on the clock, and you have to kind of focus with the problem. And I get the really good part that you were mentioning is that for patients who have a chronic pain issue or something, or addiction issue, or something like that, there's a myriad of problems. And I can't fix everything at once.
Right.
Tell me what your one problem is that I can address today. What's the one issue? I got knee pain, I got back pain, I got headaches. Okay, I got it. What's the one thing that you want done today? What's the one? And I'll get to everything else, but it's like a honey-do list. My wife gives me a list of things to do. I can't take everything at once. Give me one thing at a time. We slowly bite the apple, one bite at a time. And also, sometimes when people are too all over the map, you know, they're not focused, they basically throw up on the physician, and they don't know what to do with that. I don't know what to do with this. Either you're crazy, you're bananas, you're hysterical. These are, and that's not what you want to say, but that's how it would come across. So before you sit with the doc, maybe write a few little notes to yourself to keep yourself on task, because there is a limited time. So, okay, I got that bullet point, I got that bullet point. And if you can't do it, then perhaps you have a loved one or someone involved in your care who you can role play with, before you see that doctor. Well, and then they can help advocate for you. And you're right, because sometimes it's just not natural, because, apparently when I put that white coat on, people, think, oh, well, he's the doctor. Hey,
well, there's an inherent power differential, right?
Yeah.
Because to your point earlier, technically speaking, you're the expert in the room, and still to this day, I think there's that misnomer that doctors they're just going to fix it, right? Like, I don't feel good or something's off, I'm going to go to the doctor, they're going to fix it, and I think we sell ourselves short as patients by not kind of stepping up. And I love the idea of writing a list, right? So that, okay, we do have a finite period of time. I'm going to go in there, I'm going to say A, B, C. The doctor will help me triage myself, right? Okay, well, if we look at B and we take care of B, A and C might correct themselves.
And that is a good point, because a lot of times all these things are kind of interconnected anyway. And your first answer, your first complaint is the worst one. It's like if you take a test, your first answer is the right answer. Don't overthink it. Just tell me. Just go with it. And then, oh, okay, I got it. And then we could do, X, Y, or Z with the understanding, physicians are human beings too. They're not God, they're not Jesus. And then they might guess wrong. At the end of the day, there's a science to it, but also there's an art. And if patients who listen to this podcast, if they've had one bad experience with a physician, I might want to say to them, try someone else, just like if you get a bad haircut, sit in a different chair a month later, you still get your hair done. I get like cut in a color, but this person can't do it. This person over here has the same hair, the comb, the scissors, the brush. How come they can do a good job? Because it's very practitioner dependent. No one is, it's like meals or a restaurant or anything like that. I'm no better than someone else, but sometimes it just kind of clicks. And
Yeah.
so don't ever give up the hope or look for that care.
So then here's a question for you, because
Sorry.
you are a unicorn, right? Like, and what I mean by unicorn is like, I know a lot of pain medicine doctors, but I know a handful of addiction doctors. So you bridge the two. So having bridged the two, like, what do you recommend to somebody who does need to see a pain doctor? You know, how do they find that practitioner?
I think, so even though I do addiction, that's true. So in the pain world, I think anyone who is board certified in pain medicine is a good start. Okay. And there are a lot of people who do pain management. I'm doing air quotes.
Okay.
That could be anything. I don't know what that means. Just so it could be a neurologist, it could be a psychiatrist, it could be all these things, but you probably should see someone who's board certified in pain medicine. The ones that I think who do it best, because I'm an anesthesiologist, I served on the board of the American Society of Anesthesiology, is an anesthesiologist. And if they can't do that, then the next person who's very good would be a, come on, give me a minute, a physical medicine rehab doc, you know.
Okay.
So, and those are really good places to start. So, hang in there, 130 seconds. So it's like,
For those of you guys that are listening or watching, like, Dr. Dombrowski is literally running his practice while he's chatting with us. So like that's an awesome thing. So that's an awesome thing. Like we are able to have this conversation with you. So thank you so much.
No. I apologize, but they pinged me twice, so it must be a reason. So at the end of the day, you know, people who, if they have an addiction problem, if they had a loved one who's got an addiction problem and the loved one is still having pain issues, of course, see someone, you know, with that skill set. Now, granted, you know, there are a couple things that, you know, most things that I see are like back pain. And most people that I see are people, older folk, or people who have had previous back surgery. And now, well, your surgery's all better now. And, you know, look at your x-ray. It looks awesome, the doc says. But the patient goes, yeah, but I hurt. So at the end of the day, who do we treat, the patient or the x-ray? We always treat the patient. I really don't really care about the x-ray. I care more about what you tell me. So a couple things to that point. Let's say a patient came to me with an, you know, opiate use disorder, and because they had back surgery that didn't really turn out well. Well, we know that the opiates aren't really a good way to move forward, or maybe, but we'll get to that in a minute. What else can we do? So a lot of these patients always have sleep disturbances, always. And people with substance use disorders have sleep disturbances also. So things that work well for that are like old-time antidepressants. You're not crazy or depressed, but all the chemicals in your head that deal with pain and addiction, you know, are in your head. And they kind of respond to these antidepressants. The ones that I use in my practice called Elavil, amitriptyline. Another one is called trazodone, and the other one is called Remuron. They're, you know, they're all good. They're all fine. You know, so one works better than the other. Who knows? But you will sleep like a rock, and just getting a good night's sleep gets everything the next day markedly better. Other things, if they've had issues with opiates, is to look at medication that make opiates work better, like clonidine. If people go through withdrawals, they give them clonidine. It chills them out. Well, we found out that clonidine actually helps with pain. So I'm not going to give it to you because of an addiction problem. I'm giving it to you because it's a pain thing. That's good. We had mentioned in passing, you know, medications like Lyric or Neurontin, those nerve medication. I mean, every pain is a nerve that's firing. So if we can calm that down, probably not a bad thing. And no one ever gets better just with one medicine. That's like trying to cook only with one spice, salt. Okay, that's good start, but I need something else. That's one thing I think anesthesiologists do great, in that we do multimodal medications, many different medicines that little here, and they complement one another. So 2 + 2 isn't 4, but it's now 6. And this way we don't have the side effects. Many physicians, again, I understand, they would use medication. If that doesn't work, well, you just need more of the same. Well, this doesn't taste right. More salt. No, I don't need more salt. I need oregano. I need tarragon. I need something else in the flavor. Okay. This is how you get better. Now, a lot of people, it's too many pills. No, okay, I got it. But, you know, let's move the needle. Also, what I do, as an anesthesiologist, are procedures. So basically, a procedure is just basically putting a needle someplace to take away the pain. And again, that then shows the patient that I'm not reliant on a pill. So often, we are a pill-taking society. I take a pill, I clearly feel better. Tell me why wouldn't you get addicted? I mean, I'm getting a very positive reaction from that action.
Yeah.
So yes, I will do more of that. I'm not an idiot. I like that. So that's where you would look at injection therapy. Injection therapy is nice in that it's not, it doesn't work quickly, but it doesn't go away quickly. It lasts a while. So now you as a patient now have an understanding there's a way out of this, and it's not necessarily a pill. It might be an injection or some procedure. The second thing will last for a while, so it gives me some level of comfort so I can do PT, exercise, other things to get my life better. Like I said, success begets success. And then so that's very positive. A lot of times people become very reliant on pain medicine. I feel good in 20 minutes. I feel great. And as far as I start feeling crappy again, I better go back to 20 minutes to get, and it just clearly sets up addictive like behaviors, but it's not their fault. It's made them feel better. So that's the other thing that an anesthesiologist would or should offer. And finally, if patients, fail those things, that, oh, there's no hope for me, I'm really stuck. Okay, then there's a thing called a pacemaker for pain. No one's ever heard of this.
I've never heard of that.
If you had a bad heart, you would see a cardiologist to put a wire in your heart for your ticker, where an anesthesiologist with a certain skill set can put a wire in the epidural space, like a epidural for babies, like we do all the time for pregnancy deliveries. And the wire sends electrical signals to take away the pain in your neck, in your back, arms, legs, wherever that it is. And the good news about this technology is you get to try it out. Most surgeries you can't try out. You buy the whole enchilada hoping for a good outcome. And then, it's going to be 6 months. You got to recover. That's always hard, blah, blah, blah. And then after 6 months, hey, I'm no better. I'm actually worse. Here, because we know pain is so individual and it can be very difficult to treat, we can do this, a trial of stimulation. It's called spinal cord stimulation. And you try it out for a week. Does it help you? Now you have a success. If it doesn't help you, no harm, no foul. We take it out. You're anatomically the same. So just like the car you were driving, you didn't plunk down 30 grand on the car. You took it off the lot. Do I like the car? Do I like the handling? Do I like the steering? Do I like the stereo? If you do, buy the car. If you don't, show me something else.
Yeah.
So that, and it's more customizable because the patient will then have a remote control that they can then manage their pain with. So in other words, I want to watch TV. Great. Which station do you want to watch? Fox, MSNBC, CNN, CNBC, whatever. I can change channels of how it makes me feel. And then more importantly, I can change the volume. Oh, I need more intensity. I can turn it up, or I don't need as much. I can turn it down. So it is very customizable, and that's called spinal cord stimulation.
So wait, is that like a little pacemaker that goes in your back someplace?
Yep.
Huh.
And it's been around since the 70s, all covered by insurance. Medicare, Medicaid, everybody, so there should not be a reason if you wanted to do this that there's a financial barrier. And that's the main thing is I can come up with a great idea. Well, I can't afford it. Well, how good is that idea then? They can't do it.
That's so crazy. I've literally never heard, I've never even heard about that.
And that's why I like, interviews or on podcasts or any sort of media venue is because the public needs to know about this. I mean, there's so many physicians don't know about it. I mean, this is very inside baseball. So the more people can get out there to ask their physician, is this possible for me? Well, I don't know, but let's look about it. I mean, you can go to my website, but it's quite popular. If you look up spinal cord stimulation or SCS, and the people who do this are people or companies that make pacemakers, Medtronic, Abbott, Boston Scientific. And there are a lot of other players, but those are really kind of big in the space. So those are all kind of positive things that those patients with a chronic pain that either opiates haven't worked or opiates work, but they work too good and I got in trouble. There's a nice way. Again, if other things don't work, then you would look at that as a technique. And again, it's one of those things just to give patients hope. I think a lot of times people become very hopeless well, I tried this doesn't work. That doesn't work. I mean, I've done this for 25 years. It has to be a 95% success rate.
Oh, wow.
And that's really positive, I think, whether it's diabetic neuropathy, AIDS neuropathy, chemoneuropathy, all types of discomfort, unless God made you somehow unique, I guess you all did, but your anatomy is the same. It should work. And then lastly, I kind of said at the start, are opiates for someone who is in a substance use disorder, are they off the table forever? Well, there are two ways of thinking about this. One is we say, yes, you can't do that. The other is like, well, maybe with this caveat, we will give you medication, but we're going to be very cautious on how it's doled out to you, in terms of maybe not a month's supply, maybe a week's supply or 2 weeks, or we're going to make sure your loved one is the one that handles the medication and not you. Just so there's some type of control, because if I was an alcoholic and someone said, hey, you can drink wine now, well, do I have my bottle or do I have to get a glass? So it's a lot easier if I just had a glass at a time versus the whole bottle. Again, relatively controversial. You could think of that. Other things you could think about is, outside of, direct acting opiates, you could look at medications like buprenorphine. Buprenorphine is Suboxone. It certainly does have analgesic properties. That's how it got started in the 70s as an analgesic or pain reliever. Found not to be very good, but they found out, hey, we can repurpose this as methadone 2.0. Lastly, if patients wanted an opiate or something like that, then an anesthesiologist could do a thing called an intrathecal or spinal pump. So we're going to give you narcotics, but it's going to be in the spinal space. So just like I shared with you earlier, there's an epidural catheter, and epidural is what patients get for moms get for babies. What an anesthesiologist can do is a spinal anesthetic. So when you go to the doctor in the hospital, they put a little needle in your back, get the spinal fluid, but in the fluid they then inject local anesthetic and some narcotic. Well, we can do the same thing but with a pump. And then so you're on your narcotics, but clearly you now have no control over it. You're going to get it, but there's not an issue with respect to a diversion or misuse or taking too much, because this pump, which is like a hockey puck that slowly infuses that medication over a month's time, keeps you comfortable. So it's another, again, that's, it's not my first choice or even my third choice. That's why it's kind of the last choice, but that is possible. And the good news about these pumps is that not only is an opiate being used, which is fine, but you can also put local anesthetics in there or other medications that make the narcotic work better. So I hope that gives you some idea. There's a lot of things that can be done in terms of helping, if you just have chronic pain and not really seeing much with opiates, or you got in trouble with opiates, that there are other ways of helping.
So what about, so I have so many questions. I know Amy does too. What about like alternative things, right? Like yoga. And I mean, like I'm a cancer survivor. I had stage 2 anal cancer. They treated it like it was stage 4, so like chemo, radiation, and then chemotherapy and multiple surgeries. And I used ibuprofen and Motrin and attitude and meditation and yoga and nutrition, and like it got me through. Right.
So to that point, I mean, obviously there is a lot of science to complementary medicine. Complementary medicine, the way I understand it, it would be like, medical acupuncture, something like that. That is true. Chiropractic can work and things like that. And there's sometimes it can't do everything, by the time I see people, they've usually had tried that. That's the reason why I didn't kind of mention it. I would have had to assume that they've done those things. So by the time you get to me, you've kind of failed those things. But I did not mean to not, talk about that as a possibility. I'm not so sure about, obviously we all need good nutrition. I'm not a nutritionist, so I can't really speak to that. Reflexology, I can't speak to that. But I do know when it comes to yoga, that's basically really great stretching, deep breathing, very positive stuff. And the other thing that is true, and I think this is kind of touching on what you're saying earlier, Joanna, is meditation. So biofeedback and relaxation. So we know that, the pain is basically in my head. You know, I mean, yeah, I might have a problem, but where it registers is up in my noggin. That's true. Okay, where I feel it, how I feel, the quality. That's true. It's basically in my head. I have an anatomic problem someplace, but I register it up here. So granted, we can try medicines or surgeries or injections to take away the problem peripherally, but up here in my head, what can I do? So there's a lot of data with respect to biofeedback and relaxation techniques. So basically getting yourself to calm down, getting yourself to in quiet meditative state, whether that's prayer or yoga or something else that would be, you know, that's really important. And it's not, you know, I can't say it's everything, but again, 20% here, 20% there. Hey, you're at 40%. That's a pretty good day. And
that's an amazing day.
Yeah. And that's why it's great to put things complementing one another. You're not choosing. It's not either or, but it's usually both. But in my practice, I mean, I do recommend that. However, I really don't have the skill set to talk about. Usually people who do that would be like a psychiatrist or a social worker, things like that have those skill sets. I just don't have those, but I know it's important.
I gotcha. So that's actually a really great segue to like my next question, right? So my next question is, how does the recovery care team, the different members of it, work with you around this issue? Because this is a hot button issue, right, which is how we started.
Right. This is why this recovery care team is so important. I think it's the first time, in my understanding, that we are now working together. You would see an addiction specialist, oh, you go see your counselor, well, they'll go do this, and everyone is basically not talking to one another. We're in silo therapy. Right. You know, we're in our little silos. And we in medicine did this years ago, I mean, 30 years ago, but now what we do is talk about team-based care. So the nurse who might spend more time with the patient than the doc would say, you know, the patient forgot to mention this. Oh, why didn't they tell me that? Well, you were too busy talking or doing this. Great, good information. Let's work on that. Or someone else would give me some information. The pharmacist would call up, hey, do you know this patient's, you know, pill shopping? I didn't know that. How did I know that? Again, this is why we need to talk to one another. And recovery is obviously a multifaceted problem. So not only it is a, you know, an issue with respect to cravings and addiction and depression and anxiety, but there's also a physical component of feeling poor because I don't have my, you know, my medications or whatever. I'm going through physical withdrawals. But then I took out of these medicines because I had pain. So how can you blame me for that? I was actually trying to do the right thing. And, you know, so people were doing the right thing. And doctors were trying to do their best. So that's where, you know, you would take a step back, work together in a team-based care with a recovery coach. And again, you have to have the right person at the right tool. I mean, a doctor can spend all this time talking to you. He or she is very expensive. But maybe we have a tool that's equally as better, maybe better than the doctor and is less costly. That's really the best spot to be in. You know, I'm going to get better care for less cost. This is great. The patient wins on both fronts. And that's kind of what, you know, recovery, team-based care is all about. And again, if there's something that the physician misses or something like that, the coach would come back and talk to me about, well, they really didn't tell you about this. Oh, I didn't know that. Next visit we talk about that to move the ball forward.
Oh, I love that. So everything that I'm hearing says that we need to break up the silos that we seem to have. Like I've worked in addiction treatment for the last 12 years, I think, in different settings, right? My last setting, I worked at a facility where I actually still work there. I do groups and stuff there where we have a pain program. And so, you know, one of the things I noticed, and in the course of doing BPSAs and talking to patients, was that people would go to 10 or 15 different addiction treatment places of all sorts on all sorts of levels of care, right? And nobody was talking to each other.
Right. Yeah, I mean, and again, it's not surprising for people who have an addiction problem and that, you know, that they might fail because, well, everyone's great at camp rehab. I love camp rehab. It's awesome. You know, I mean, I got my meals for me. I'm working out. I got yoga going. But then I got to go home and face my family and the job that I hate and all that. What do you think's going to happen? That's why the success rates are very challenging at times. I mean,
Yeah.
it's, and that's why, and also in this kind of problem being that it's so deep seated, deep in the brain, the basic functions, as we started talking about, just the feeling of that emotion of being loved and accepted, this tremendous warmth and this great feeling. That's hard to get, say, I don't want any more of that. That's hard to say, so
Yeah.
I can understand that. So, but we have to figure out another way to, okay, we can't get you all the way there, but if we can use other things to make it better, great. But again, for those people who have addictions problems, if they go to a rehab center, if they had a pain problem, well, when they leave sober, they still got their pain problem. So that's where we got to say, do a good handoff. We got you fixed here. Now go here immediately. Because otherwise it's just going to come unraveled again.
Which is one of the things that recovery coaches can help to do, is to hold people's hands from here to here and then have a recovery coach coordinator in the middle of it.
And because as we talked about earlier, medicine is not necessarily that complex, but if I'm a patient, I don't know where to start. Like, if I'm a mechanic, I don't know how the engine works. You show it to me, I know where the gas goes. So we all have different skill sets. So
I think is a huge problem.
Right. So that's
where do you
why
start?
Right. So that's why a coach or someone to manage that care for the patient would then show you, go here next, go there next, organize things, because it's coming at them, the patient, from so many different directions, they really can't know how to move forward. And I understand that. I mean, me as the mechanic, I go to the mechanic, I go, hey, it's making a squeaky sound. I mean, well, your ball. I don't know how to get started.
Right.
So
we're back to the passive patient, right? Because
well, they might be passive, but they also just might be overwhelmed. I don't, sure. I'm active. I would like to get started, but I don't know where to start. I don't know how the system works. This is foreign to me, and it would be because they're not in the medical field.
And quite frankly, we're just addressing the mechanics of it all. We haven't even as we're having this conversation, I mean, that's just step 1, step 2, step 3. You haven't even tacked on the fact that these people are full of shame, full of guilt, overwhelmed. You know what I mean? They're lost. They don't know what the hell is going on with them emotionally. Before, I mean, I love what you said. I mean, it's being sober in rehab is the easiest thing on the planet. I love being sober in rehab. It's when the rubber met the road that I was like, oh shit, what am I supposed to do now?
Sure.
No.
So that's why when people say the barrier to recovery is because they leave our treatment centers, they leave our, they're in a halfway house, they're doing the deal, the family and everybody sees them as but you're sober, and it's but that's not enough.
Right. Yeah, I mean, but again, I think also the key thing is we talk about shame and all those things. These are very powerful feelings, very powerful. And a lot of times when people are in the world of addiction, they tend to be very knowledgeable of that from a personal side. I'm 5 months sober. I'm 10 years sober, whatever the case might be. People often ask me, so how long have you been sober now? I go, well, I've never been sober. I don't have a problem. I mean, so it's unfortunate that people might look at that to say, well, you don't know what I'm going through. Now that's obviously physically true. That is true to some extent, but there is a component. If we drill down, everyone has a habit or a problem that they have shame with or have a trouble letting go of, and they always kind of fall back on it. We are fallen individuals. I'm Catholic. I mean, we're fallen human beings, that's been drilled in my head. So even though I tell patients, I may not know exactly what you're going through, I can appreciate from this perspective. And that's the best we can do as physicians. I mean, I've never had a baby, but I'm sure labor's hard. I mean, I never had a brain tumor, but I'm sure that's a really bad headache. I mean,
and you're there as a resource.
Right.
Hopefully, right? That, I mean, because I know exactly what you mean. I have thought that. honestly. Like first, you first get sober and you are, you're so raw, right?
Yeah.
And so your instinct, at least for me, was, there's no way you could understand how I feel. I'm so freaking special, right?
Right.
You could never imagine my torture. But and I'm not diminishing the plight, right? But that's not why they come to you, right? Like they're not there so that you can like empathize at similar.
I guess what I was trying to say is what you had mentioned earlier is to kind of disarm the patient, to say, you know what, just tell me how it is. It's okay. I mean, I go, so when do you use, it's now 12 o'clock. What, this morning?
Right.
Not before you got here. I don't care. It makes no difference to me. I mean, I always ask people, well, how much are you using? 10 caps? Oh, I would never do that, or what? I mean, whatever. You just kind of try to disarm people. And then they just are trusting in you, and you can just have an honest conversation or as the best you can. And again, no relationship starts out perfect. It's like dating. The physician is like dating. The first one is just the icebreaker, going for the coffee.
I love that.
As you get to know the person, then you get more comfortable talking to that individual. It's not going to be love at first sight. Hey, when are we getting hitched?
Right.
The first day, that's impossible. And that's not your fault or the doctor's fault. It's just the way we are as human beings. We always build up trust on both parties. There's trust on my side too, as well as the patient.
Yeah, absolutely.
Ooh, talk to us about that, because I think like that's the thing, right? Like we're thinking about this entirely from like the person with pain. Like I do think, because I'm part of the recovery care team, but like for people that aren't part of the team, like, or are new to the team, like what goes through your head when you see us? And by us, I mean people in recovery,
Right.
and
Well, I mean, I guess it's one of those things. I look at you as specialists and a great part of the team, because you're going to know a different facet of that patient that I may not see or I would never see, because that's a different skill set that you have. I mean, that's the other thing that is really important. I mean, yeah, doctor's great and all that. I'm not minimizing that, but I can't know everything. It's impossible. And that's why, like, that's why we have specialists,
the great Oz.
I mean, or pulmonologist or whatever. So you have a specialty as well that can appreciate that patient or their road to recovery in a different way that I may never, ever get. And you know what? It's okay, because that's not my job. We have different jobs, and you do that, I do this, but we work together for that same patient. Just like not this is, I guess, a bad analogy about medicine as almost like a conveyor belt, like a factory. Each person on the assembly line does another part for the car. You do the windshield, you do the wheels, you got the engine, you put the stereo in. But it's all the one car that we're working together on. At the end of the day, it comes out the line assembled.
Yeah.
The engine is not
and each part is so important.
Right. And again, some people might say, I know how to put engines. I don't know how to do windshields. Okay, that's fine. Just keep doing the engines.
Yeah.
And what I hear you saying too is like, this gives us this, all of us, you and us, right? Like, and everybody else at the table, like the ability to be, to really dig deep into what we're doing, and also to practice compassion.
Yes. I mean, and that's the other thing I think, we have to, look, compassion, okay, is a two-way street. So compassion is for the, patient, but also we need to have compassion for ourselves. I mean, what we are doing can be very consuming. And sometimes in the middle of the crisis, take your own pulse. Don't take the patient's pulse, take your pulse. And take a step back and things like that. And I have to learn that, that role every day. It's kind of, okay, hang in there. So that's kind of important. And the other, and the other thing, just in passing with respect to anesthesiology and addiction, obviously there are great ways of sobriety, and we had kind of alluded to those earlier in terms of like, buprenorphine products, methadone products, or just straight sobriety products, just will do nothing. And sometimes people can be kind of militant, it's got to be this way or that way, and okay, I'm not a really militant kind of guy. But there is a way of or Vivitrol shots or, Sublocade shots. Okay. So on the, one other thing that can help with sobriety that lasts over 6 months is an implant. And it's an implant of naltrexone like the Vivitrol shot, but instead of lasting 25 days or 30 days, it lasts 6 months. And that's really great for patients in that they don't need to keep coming back to the doctor for their recovery. The implant gets done in the doctor's office. It gets tucked underneath the skin. Oh, maybe the size of maybe like a Tootsie Roll, and over 6 months it kind of dissolves. And the good news about this is that sometimes patients in recovery don't come back for that next shot, so we kind of lost them. So here you're going to take your medication unless you get a pocket knife and cut it out. You're going to take that medicine, and that's kind of a nice help too. And if you want to put out there, it's called BioCorrex, BIOCROXX, BioCorrex. And they've got a website that can, they do, not only the implant, but they also do counseling, telemedicine as well. And, I do that, offer that to patients for people who have been to rehab for a bunch of times, keep failing. So this way, if you do the implant, there's a bit of an insurance policy that you're going to hopefully stay sober this time around. But it's another interesting that probably not many people know about.
No, absolutely not.
Do you work alongside or in tandem with any training centers? Like,
sure.
Yeah.
So I am the medical director at Tranquility Woods. It's a great practice up in Maryland. They've got a great inpatient service as well as, a little longer stay that they have. They take all insurances because a lot of these things can be very expensive. And they've done a great job in offering really good care at a fair, and they take insurance. I think when you start to do that, that's fair. Some of these places are uber expensive, and it's great, but you really can't take care of everybody because we're not all that blessed to have that level of financial security.
I've heard amazing things about Tranquility Woods.
Yeah, right. Me too.
So and again, just to that point, it's holistic, like what we're talking about. So people with pain issues, they're kind enough to send to me. We might do an injection, send them back, look at their meds, get them tuned up, do the yoga, biofeedback, relaxation, acupuncture. So they offer everything at Tranquility Woods, which is a very, it makes me very proud to be associated with that. And then obviously I'm fortunate. I run a couple of methadone clinics. And they are what they are. They are methadone clinics, and then and the main thing is counseling, which is a big thing for these patients. Not just, okay, I get my methadone and go. That is not medical care. That is just fraud.
Thank you for saying that.
We're gonna sit you down, and we're gonna have 10 minutes of sobriety. And you see all these other people here, they're sober too, because this is the one chance in that patient's life they're around sober people. Which is great. Okay, and then a lot of the big thing I think we're going to see a problem we had talked about earlier in terms of the opiate crisis. How did we get here? My guess is, and you can archive this, we're going to see a buprenorphine problem because right now everyone is writing buprenorphine. PAs, NPs, doctors. Oh, we got a crisis. Right. Script. It's a harm reduction. Oh, I got it, but I can't tell you how many people divert their scripts because how do I know that? It's because I'm seeing them, and where you got like butter on the street. So that is a problem.
Are you a fan? Are you a believer in the idea that they can be used in the short term for like a rapid taper?
Yeah. Of course. I'm not against it. But when we start seeing long-term use.
Yeah. I mean, the rapid taper, I get. The people on it for years, that to me is a little alarming because there is so much ability to play.
Yeah, I mean, or when you see patients on these for months to years.
Right.
harm reduction, I understand, but are we ever going to get off this?
Yeah.
And granted, in the physician's role, if you get off it, that means I get one less patient. You know,
that's our job, is to get you out, is to not have you as a patient, is to heal you.
Yeah.
Well, you are very ethical. There's some docs that may not be as understanding as you, and they say, well, you know, it's like the psychiatrist. You know, I'm glad we worked on that. You know, that your problem with your dad. Now, what about your mom? Oh my God, that's another 6 months we're going to talk about that. Or the allergist. Okay, well, we got the cats down, but that mold issue, you got to do some allergy shots for that mold. So, you know, this is where you have to be ethical in terms of, you know, okay, it seems like you've got your sobriety worked out. You've changed your life. You've changed your friends. You've changed your behavior. That's great. Do you think you're ready to change this? Because what you're doing, although is well intended, is not necessarily normal. I'm not in a, you know, let's see. Hold on 30 seconds. Okay.
Okay.
Let's see, where was I going with this? Okay, it's long buprenorphine use. Sometimes people have a hard time getting onto that. It's worse than methadone. You know, so what are we really accomplishing for this patient? Okay, you're not addicted to heroin. Well, that's really good. But now I'm addicted to this. Well, okay, it's more socially acceptable, but is that really better? I'm not sure. I mean, these are just questions. I'm not being smart about it. I'm just questioning. If you're sober and stable and this is what you want, I think that's great. But to your point, I'm always a big believer in whether it's a methadone program or something like that. If you've got your life together, get out of here. This is not normal coming here. You know, a lot of people, you know, it's a real comfort. It's a great sense of security and things like that. I got it. And we don't want to, you know, kick you to the curb if you're going to relapse. But if you say, you know, you're riding the bike, my hands are there, the training wheels are off, you're now on your own. Look at you, look, you're on your own. You're pedaling, you're good. And then and then this is what it's supposed to be like. And that's why, like in my methadone clinics, I mean, I never really go, I mean, 80 to 120 or something like that, or maybe 150. But when you start seeing 300 milligrams or something like that of methadone, they'll never get off.
That's,
you know, I mean, and then
is there a reasonable amount of time expected, or maybe that's a subjective question, I'm not sure, but
I think that is subjective. I would say I mean, the science is kind of showing at least takes 6 months at a minimum to get your mind right in terms of getting good established behaviors, you know, habits, good habits. You know, my habit was using, my friends were using, my whole world was this. You know, all of a sudden to change that overnight is impossible. So it's like weight loss or anything. You know, okay, I got a pill that's going to keep me from, you know, withdrawing. Great. But I need to go to the gym. I need to work on my diet. I got other things I got to buff up. And, you know, I get on the scale. I'm still fat as a house. Give it a month. Let's see what happens in a month. The next, you know, I'm down a pound. Great. You know, now granted, hopefully, a little, you know, I'm trying to lose some weight myself, so I get a little frustrated. But, you know, I'm talking 6 months now, but
I got the COVID-12, so I get you.
Yeah, it's moving in the right direction. But to the point is that it's really about 6 months to really get your mind right. And again, that's 6 months of stability. And then some people, it takes longer than that. Some people, they fail and they come back. Okay. But so that's why I always leave it to the patient. How is your life going? What do you want to do? Well, I think I've got it now. Okay, great. So we might do less medication. Are you been stable with that? You know what? I'm actually doing pretty good with the less. Great. Let's maybe take the training wheels off now. Yeah. Or, you know, I got a little uncomfortable. Great. Let's go back, because we don't want you falling off the bike. You know, so we never shame someone. Oh, you couldn't do it. Boo freaking who? No, just fine. We tried it. Not ready. Great. It's like the kid with the bike. You know what? I'm not ready to take the training wheels off. It's fine. Don't worry. When you get your balance in life, and that's a really great analogy with the bike, everyone's trying to find its place.
Yeah, that makes sense.
And that's where recovery coaches and counselors and all come in too, because we can be like, hey, what's it going to take to keep you on the bike? Like, do you need to get stronger core? Like, do you need to like learn to think about it differently? Do we need to focus you so you're looking longer down the road?
Right.
Do we need to take all the thumb off your eyeballs?
Right. And that's where, again, the coach does everything, and the physician, takes that guidance and saying, okay, let's do this. And then obviously the coach will be, very much in tune with that patient. I see we change things. How's it going? Okay, great. And that's why, Suboxone is very, it's a great product, or buprenorphine is a great product. But if you try to decrease it, the patient will see physically a change in what that looks like.
Yeah.
I was taking 3, now I'm taking 2. I can physically see a change. Where if you were doing methadone, I'm not saying one is better than the other, but methadone, the patient doesn't know what they're getting. So it's sort of a blind taper. So psychologically, all of a sudden, if I'm, oh, wait a minute, my drink, you're not making it strong like you used to. I saw the shot glass. Here, you poured half a shot glass. Wait a minute. I missed that. First, if you didn't see what I did with you, then, I don't have the visual clues of I'm getting less.
Oh my God, that makes perfect sense.
Yeah, that's an interesting point. It like the whole placebo a little bit.
Placebo is very important in medicine. Placebo is 30% of medicine. That just means patients want to get better. That's all.
Yeah.
So good. I want to use that to my advantage.
Yeah. Hell yeah, absolutely. I gotta ask, do you seem very comfortable not being the showstopper? You seem to be very at peace being an essential part of an ensemble in terms of taking care of patients. Would you say that is common, or that's like a culture that you're trying to be a component of?
Well, I know about myself. Now my wife would disagree with you dramatically. I love being the center of a party. And
me too. I totally get that.
Look at me. You can't keep a camera or a phone away from me. There's an interview to be had. Hey, I'll do it. Not a problem. So yeah. I'm not a wallflower. But with that understanding is that I know it's not all about me. Again, don't tell my wife that, because she believes it is. I think it's all about me.
It takes a long time to break them in. I get it.
Right. So, but when it comes to something like this, I'm incredibly comfortable in knowing what I know and knowing what I don't know. And I'm just honest about that. I think that's very fair. How can I know everything or know everything about all possibilities? And that's why I surround myself with good people, coaches, nurses, staff. Everybody represent me, but we're doing this for one goal, that's better patient care.
Yeah.
I love that. So that makes me, so I have to ask one thing, but I also want to say congratulations, because you are the president-elect of ASAM, the American Society of Addiction Medicine, which is kind of a big deal in Maryland.
I thank you. I want to clarify that, because I want blowing up too much on the podcast. So I am the incoming president, but of the DC Maryland Society. So just a small, little nugget here in the DMV.
Congratulations, though. That's wonderful.
Versus ASAM, which is the national. I'm not that good.
I'm very glad that you said that, because I hooked Maryland on there. It was so...
No. So it's a DC Maryland Society. So it's a chapter, and obviously we're addiction specialists advocating, not only giving, for educating other physicians in terms of appropriate care, but obviously legislating or lobbying on behalf of patients in terms of rehabilitation, things like that. So it's multifaceted. But yes, I'm very happy, and I want to get more DC members involved. And members does not mean physicians. Members means PAs, nurse practitioners, coaches, all those things. Because to your point, I want the society to represent what we're doing in reality. In reality, physicians are there, yes, but we're dealing with a lot of other people. Well, the society should recognize that as well, and then reflect that to be and as we work together, both in the in the community, but also as a medical society.
Oh, wow, that's
How would
fantastic.
people be involved?
So yeah, so you could join the American Society of Addiction Medicine, and I know. So if you want to join that, it's I should know the website, but I know it's ASAM. I don't know if it's probably .org. I'm assuming, American Society of Addiction Medicine, and I'm sure on the banner page will be a join. Click here, and then once you do that, I mean, it's very minimal to join. But the other thing is, when you do join, you then get access to obviously educational materials and things like that, conferences, et cetera. Conferences have been kind of difficult over the past year with the COVID situation, but we're getting beyond that now, so we're going to move forward.
Absolutely. So can you tell us, thank you for that. And also, can you tell us what is ASAM, and also what is this ASAM level of care that everybody's talking about?
So obviously, the American Society of Addiction Medicine is like any medical specialty. Just like I was a board member and the secretary of the American Society of Anesthesiologists. So it is an professional organization representing those individual physicians, and they're and advocating on those physicians' behalf, say to the government in terms of payment issues, the government in terms of legal issues or practice issues, but also the societies are then looked to as experts in the field to the rest of the House of Medicine. Hey, are we doing this right?
Oh, you're muted, sir.
Nope. Okay. What is that level of care? So, to that point, that's what a medical society does. Educational advocacy and obviously fellowship for other physicians and or the team. You had mentioned the ASAM protocol or ASAM something or other method.
Levels of care. Like, people talk about the levels of care a lot, but I don't think that everybody knows what they're talking about.
I'll be part of that group. I'm not really sure what levels of care you're talking about either, so I could look it up for you, but I don't want to waste the time. Whatever it is, it's not. Maybe I would think of it as something else. I really don't know what that terminology means, but I can look it up and get back to you after this, recording.
Oh, that'd be awesome. Can we have you come back another time?
Sure, I got nothing to do. I'm easy.
Oh, I love it. Look at that.
And obviously, if you wanted to throw something out in terms of Q&A to your membership, or to people listening to the podcast, hey, at the end of this, if you want to ask the physician a question or the coach a question, why don't you call into it?
Absolutely.
Yeah, I would love to do that. Yeah, that would be super cool.
Yeah, let's do that. Okay, we're gonna hook up with you after to schedule that.
Okay, great. And like I said, if there's some interest in that, I think that's important. But this is a great dialogue just to kind of understand. I mean, I could talk a long time for this, but it's just really the 30,000 foot view for patients to kind of understand the landscape of pain medicine, addiction, and things like that.
Yeah, I think my biggest takeaway from having an opportunity to chat with you today is that while perhaps my perception of things that would seem somewhat inaccessible are actually much more accessible than you realize, and that there is a ton of help out there.
I think you're right. Sometimes in people in recovery, I got to go to the methadone clinic. I got to go see this person. I got to do the counseling. Oh, come on, what a hassle.
Yeah,
it is a hassle. Yeah, I mean, it's a lot easier staying where you are. And so often we set up barriers for our own recovery, our own benefit, but
indeed,
take those away. I mean, if you believe it's difficult, that's fine, but it's physically not that hard to see me.
It's not
that hard, I mean, it's okay. And again, there's no financial, barrier. So whether it's, I take Medicaid, or other doctors take Medicaid.
Yeah.
You can get help. You might have to try, but you can get it. Don't ever say that people don't care or, it's so hard here. Yeah, it could be, but that's why you have a coach or other ones to help guide you to get there.
That's great. And that's why I asked you how to reach you, right? Like, for people listening, like it really can be a phone call. The phone might weigh 1,000,000 pounds, but if you pick it up, somebody's going to answer.
Yeah, I mean, and you know, and that is physically true. So again, I hate, you know, trying to lose weight. Oh, geez, I got to go to the gym. I'm really kind of tired. I don't feel like going. Hey, I'm not going to the gym then and running, and don't expect any weight loss. No kidding. Yes,
Right, right.
you have set yourself up not to accomplish that because, well, if I had to go to the gym, I don't really want to do that. I mean, we all have this experience for anything.
Yeah.
It doesn't make any difference what it is. For that individual, it's as equally as important as to you who perhaps that have a substance use disorder. It's equally as important. Maybe different look at, but it's the same thing chemically.
Well, it's just really replacement. I mean, because like as you're saying that, I'm like, well, it takes me the same amount of effort and energy and work to get my stuff than it does to, you know, pick up the phone and call someone and get help and like set some goals and decide I want to stay sober. And, you know, like this is a much more valuable life.
Right. But the other stuff's more fun. You know, I mean, what the hell? I mean, you know, it's you know, yeah, you know, this is great. I want to escape. I mean, a lot of this is escapism,
Yeah.
you know, and I understand that. And what happens is we start to feel worthless. And I want to escape because I hate feeling worthless. I feel very bad about myself. And I know my use will at least have me escape for a little while. And then when I start to sober up, now I feel twice as bad because, you know, I really screwed up. And I better escape that now. And then where do you think it ends? I mean, and again, not that you have to have a 12-step program or a higher power, all that. As I said, I'm Catholic. Is that, you know, this is almost satanic. You know, one of the words for Satan is accuser.
Yes.
He accuses you of being this piece of trash. And sure enough, you do this to yourself, and damned if he wasn't right, and you feel worse about yourself and worse about yourself and unlovable about yourself. This is truly playing into those, you know, that vein, that dark vein. And so looking for the light or looking for someone love, we're all looking for love and acceptance in some form or fashion. And what we're trying to do, hopefully, when you get to recovery, is that I can have sober love. I know people love me because I'm not giving them bucks for my fix. I truly am loved and lovable and worthy. And when you do the other things, you become worth less. And that's a very dark place.
Yeah, absolutely. So, oh, you want to go ahead?
No, I was going to ask you, are you going to?
I was getting ready to ask the final two.
Okay, good. I'm curious.
You want to go ahead and ask them?
No, you do it. I want to know the answers.
Okay. So final two questions for today are, we'll come up with final two for next time. But for today, it is at the end of your career, when you stop doing this, what do you hope is your legacy? What are you doing all of this for?
Oh, that's great. So I know I'm on this planet for a very short period of time, but as a physician, or you, or we all do this, I have the ability to touch people in a very profound manner and maybe help with their road to recovery or sobriety or their pain. You know, they've been to all of these pain doctors, and for whatever reason, you know, they saw me and, wow, I'm markedly better, or I'm different, I'm more functioning. I still have the same level, but I'm doing so much better. My outlook is better and things like that. And that legacy will outlive me. You know, when I'm dead and gone, they still might remember me. And again, you know, there is two components of someone's, you know, mortal life. One, it's when you're on the planet, that's one thing. And the other is when the person who remembered you and then they died, then you are truly gone. Yeah. You know, you have yourself, but then there's a memory of you. But once that person with the memory of you is gone, well, then you're gone. So, you know, like I said, if I can help out with at least the first part of, you know, helping people, that's what all physicians do. I bet anyone in this field wants that for themselves. I mean, you know, we're in it, you know, really because, I mean, money's there, yes, but there's a lot of money in other jobs. But we're truly doing it because you care and you want to see a good outcome. And it's very satisfying what I do, because I physically see a change in these patients. I mean, and men like immediate gratification. I want immediate. I want you better now. I want this now. And that's what we do. That's what men do. Maybe ladies are different, but men want immediate gratification. And to that point, when I give an injection, and a minute later you're better. Oh, that makes me feel awesome. That's great. And even with addiction, within a month's time, if they stuck with the program, I remember what that person's like, and I can see, hey, you're gaining weight. You look like you're a little put together now. This is great news. And then you reflect it back to them and go, yeah, I guess that's true. Because it's hard for them to see themselves.
Yeah.
So I think that's, by me reflecting that, I think that's kind of positive. So, yeah. So that's kind of what my legacy, what I would like it to be. And, he was a nice guy and all that sort of stuff. And, and hopefully, again, as a Catholic, just treating people as I would like to be treated. I think that's always is a good way to move forward, no matter what faith you might be. I think that's fair. But that's what I'd like to, have in my background, in my legacy.
I love that. I love that.
So what's your second question?
The second question is people are going to be listening to this. So
Yep.
How can anyone reach out to you, find out more about you? Like, how can we support you in your work?
Yes.
Well, thank you. Like everyone has a website, so you can look me up as my name is John Dombrowski, Dombrowski. I'm on, on the internet, or the practice is called the Washington Pain Center. And then the other aspect is and obviously Tranquility Woods, has their own website, and either one of those ways is for the recovery of the pain, or the implant for sobriety. Those are all good ways of looking. And I do have a YouTube channel. You can look me up under YouTube. I should have some videos there as well.
Very cool.
But they're also posted, if I'm not mistaken, on the website. Unfortunately, I'm not as tech savvy as perhaps I should be, but hey, I'm getting older, and
It's one step at a time, Doc. One step at a time.
Yeah, exactly. But I'm getting it. But that's how they can find me. So Washington Pain Center, or just John Dombrowski, MD, will find me.
Awesome.
Thank you for that. Yeah. And thank you so much for your time today. It's been
My pleasure.
Really, really awesome getting to know you and listening to your work. And you're obviously exceptionally passionate about what you're doing. And as somebody who is in recovery and loves being in recovery, I have the utmost respect for your desire to help. I think that's amazing.
Well, thank you. That really is heartfelt, and I know that. And hearing that really is a nice way to end my day. Thanks.
Good. Yes, please enjoy the weekend. Right? It's for I think.
Yeah, that sounds great. Yeah. It's 5 o'clock.
I'm with Amy.
Yeah.
It's 5 o'clock somewhere.
I'm
with Amy. Thank you so much for doing this.
You betcha.
Like this is I've been in Zoom rooms with you for, the last, I don't know, year maybe. And every single time I see you, I'm like, I really like this guy. He's got a lot to offer. And more than that, like, you have so much joy about what you're doing and passion. I love that. Thank you so much for doing what you do and for being part of this podcast.
Oh, you're so welcome.
All right, well, keep up the good work, Dr. Dombrowski.
Yeah, okay, and like I said, if you want, you can certainly give her a look forward in the future. I like the idea of questions that might come from the audience is always a great way to start. But yeah, I look forward to that in the future.
Awesome.
Thank you so much. Have a great evening. Appreciate
right,
the time.
I'll let you go.
Bye.
Bye, buddy. Thanks.